On to chapter 1, talking about edema. We're going to review edema because we talked about it in PTA 273. And we're going to talk about compression as a treatment for edema and a few other things that compression can treat. So compression, of course, is a mechanical modality. And we are going to talk about as usual, indications, contraindications, and precautions. And we're going to practice it in the lab. In the lab, we're also going to have a PTA who is a certified lymphedema therapist come and talk to us and mostly demonstrate some techniques that we can use, manual techniques for manual lymphatic drainage and compression wrapping. So that'll be fun. That'll be in the November lab when we're all at Whatcom. So the learning objectives for this chapter are definitions, defining edema, hydrostatic pressure, osmotic pressure. These should not be new concepts to you. The roles of osmotic and hydrostatic pressure in maintaining normal fluid equilibrium. Again, no news here. The role of veins, lymphatics in maintaining normal fluid equilibrium. Common reasons for developing edema. Remember, there are 4 of them from 273. Causes of venous insufficiency, reasons why lymphedema may occur, the differences between regular edema, if you want to say it that way, and lymphedema, and why a lymphedema therapist is critical in the management of lymphedema, and the functional consequences of edema, how compression reduces that, 3 different applications of compression therapy, and general contraindications and precautions for compression. So on to it. So the effects of external compression in any situation, external compression can improve venous and lymphatic circulation because it increases external hydrostatic pressure. Intermittent compression can be a little more effective than static at times because it can sort of milk fluids from proximal to distal vessels. So when we're doing manual lymph drainage, we're usually working the fluid up, and intermittent compression can kind of do that too. And we'll talk about different types of intermittent compression. External compression also limits the size and shape of tissue. And compression garments are often used after amputations or burns or cancer therapy if someone has lymphedema. So compression garments are a really commonly used application of compression. External compression increases tissue temperature, and it may increase the activity of temperature-sensitive collagenases, which are enzymes that break down collagen, to control scar formation. So lots of, you don't think of external compression as having that many effects, but it really does have a lot of effects. So if you remember these causes of edema, imbalance between hydrostatic and osmotic pressure inside and outside of vessels. So that can be caused by venous or lymphatic obstruction or insufficiency, increased capillary permeability, immobility, and pregnancy can add to that, and systemic diseases, which we do generally not treat with compression. We need to treat the cause instead of treating the effect. So in general, those are the causes. But remember that we talked about in 273, increased capillary permeability. So more fluid is getting into the interstitial space. Venous or lymphatic obstruction, so fluid can't get out of the interstitial space, and anything that changes the balance between hydrostatic and osmotic pressure. So hydrostatic pressure, remember, is the pushing pressure from blood pressure and from muscles pushing on the area, the muscle pump. And hydrostatic pressure causes fluid to flow out of the vessels. Osmotic pressure, fluid flows into the vessels. And so osmotic pressure is a pulling pressure. So normally hydrostatic pressure is a little bit higher at the arterial end of a capillary bed. So fluid goes out, taking fluid and nutrients to the cells. And osmotic pressure is a little bit higher at the venous end of the capillary bed, taking up the fluid and waste products from the cells and returning it to the general circulation via the lymph system. So when everything is normal in healthy vessels, that's great. It works. When things go wrong, that's when you have to intervene. So edema caused by venous insufficiency, when you have healthy vessels, muscles contract, valves open, the fluid flows forward, the muscles relax, the valve close, and there's no backflow. If you have valves that are unable to close, then you get backflow, and that's considered venous insufficiency. So if you have backflow, the fluid's not going to go in its normal way. You're not going to have normal hydrostatic pressure. It's not going to be taken up by the lymph, and it can result in edema. So venous insufficiency puts a monkey wrench in the works. So compression reduces edema by increasing extravascular hydrostatic pressure. It promotes circulation, and it may move fluid proximally through the vessel. So it moves it from distal to proximal. And when we're doing lymphatic drainage massage, manual lymphatic drainage, we move the fluid from distal to proximal. Again, that's the way we want to do it. But compression can help do that. So if somebody has a venous stasis ulcer, this is often a time when we might use compression therapy. An area of tissue breakdown and necrosis due to impaired venous circulation. So we have those valves that won't close, so we get that backflow. Usually venous ulcers are large flat ulcers on the distal legs in association with edema. And in the next year, we'll talk about wound care, and we will talk about venous ulcers versus arterial ulcers and the different treatment that we do for them. Compression is the cornerstone of venous ulcer treatment. It can improve venous circulation, improve the rate of healing those venous stasis ulcers, and multi-layered compression is more effective than a single layer. And we'll look at some different compression systems a little bit later in this lecture. So compression can be helpful for DVT prevention. So DVT risk increases with reduced local circulation. So compression can increase circulation and reduce DVT formation. If your DVT risk, your local circulation can be reduced just if you're immobile after surgery or you're immobile after an illness. So you have an increased risk of DVTs. Compression is most effective when used in combination with other forms of DVT prophylaxis, like blood thinner medications. It is also effective when used in combination with exercise, because then you get the muscle pump going to increase circulation when possible. After amputation, the residual limb needs to be shaped to prepare for functional weight bearing on a prosthetic leg. So static and intermittent compression are both used. Intermittent compression can reduce residual limb in approximately half the time of other techniques, reduce the size of the residual limb. The interesting thing about amputations is the residual limb is always changing. So the person is always going to, throughout the person's lifetime, that person's going to have to adapt. And one of the things we do when we're doing prosthetic training or rehab after amputation is we're teaching the person how to manage the changes in their residual limb. And compression wrapping can be one way to do it. If you have burns or other causes of hypertrophic scarring, it's a common complication of deep burns. The scar is not pliable, it has a raised appearance. Compression of 20 to 30 millimeters of mercury for 23 hours a day is recommended to prevent or reduce excessive scar height. The compression also acts as a mold for the growth of new tissue. So you want to prevent hypertrophic scarring as much as possible and reduce excessive scar height, and compression is a an easy, basically, way to do it. So contraindications for intermittent or sequential compression pumps, which you'll see in the hospital and in outpatient settings. You don't want to use them if people have heart failure or pulmonary edema. You don't want to, because if you don't want to return fluid to a failing heart, that's and you don't want to get more fluid in your edematous lungs. If you've had a recent or acute DVT or thrombophlebitis or pulmonary embolism, you don't want to use um, compression pumps. Obstructed lymphatic or venous return, because that doesn't work. You have to manage it in a different way. Severe peripheral artery disease, because the peripheral arteries are affected and it's going to change the way the effect that compression has on the body. Acute local skin infection, it could be irritated by compression pumps. Significant hyperproteinemia. So when you have hypoproteinemia, you have lowered blood proteins, it affects your osmotic pressure. So your osmotic pressure is not working. You don't want to add more hydrostatic pressure because you're already out of balance. Acute trauma or fracture, I think it's obvious why you wouldn't want to use compression pumps in that case. And arterial revascularization in a healing situation. So precautions for compression, impaired sensation or mentation, uncontrolled hypertension, you don't want to add more pressure to the system, cancer, stroke or significant cerebrovascular insufficiency. Again, you don't want to add more pressure to the system. Or over superficial peripheral nerves to the point where it causes numbness. So you got to be careful about that. Potential adverse effects of compression, you can aggravate the condition causing the edema. If the condition causing the edema is heart failure, and you use compression to return more fluid to the heart, it makes the heart work harder and it makes the condition worse. So you also don't want to impair circulation with excessive pressure. So the amount of pressure that you use in compression is important. In general, of course, the patient's going to be evaluated and determine the appropriateness and safety. Selecting the appropriate form of compression, explaining the procedure and the rationale to the patient, applying the compression, and when the treatment is complete, you assess the outcome and then you document it. One of the ways that you assess the outcome of edema reduction with compression is you measure the limb, then you put your compression wrapping on, and when you take it off, you measure the limb again. So just with a tape measure. So usually there are different systems for doing it. Usually you start at the metatarsal heads and you measure every 10 centimeters up. There might be some other systems where you measure at smaller intervals, but that's basically it. And you record that all, and that's all included in your documentation as well. So compression bandaging, short stretch bandages develop a high working pressure, um, like pressure during muscle contraction, and short stretch bandages are what are usually used for lymphedema wrapping. Long stretch bandages develop a high resting pressure, so pressure at rest. So usually short stretch bandages are the ones that are used for wrapping residual limbs and lymphedema treatment. An Uniboot is for high working pressure. It's a semi-rigid bandage formed of zinc oxide impregnated gauze, and it's used to exert pressure in the lower extremity. A lot of times it's used to shape residual limbs. It is applied by the healthcare provider, so the PT or PTA, or sometimes applied by a nurse. It can be used in combination with short stretch bandages. And those are multi-layer compression bandage systems. So combining inelastic, so the Uniboot is inelastic. The compression bandages are elastic, whether they're short stretch or long stretch. And so when you combine inelastic and elastic, you have both working and resting pressure. And so it's a more comprehensive. So with limb shaping, a lot of times that's what you want. So the multi-layer compression wrap is 2, 3, or 4 layers of different bandages. And we'll do some demos in the lab. It'll be fun. So compression garments are usually recommended for treatment of lymphedema, and there are various degrees of compression. They are custom fit to the individual. They're quite expensive. And once somebody gets down to you're doing manual lymph drainage and compression wrapping with bandages, once they get down to the size they want to be, that's when they're measured for the compression garment so they can stay that size. And so those are custom for each person. A Velcro closure compression device, it's inelastic and it's adjustable. So a lot of times people will use that as their continuing garment after they finish therapy. Intermittent pneumatic compression, a pump provides the force for compression and it's attached to a chambered sleeve via a hose. Usually people do it on an outpatient basis at home, and the provider, it's prescribed by a doctor or a physical therapist, and the provider for the intermittent compression comes in and treats the person in their home. It's like a home health thing, and it can be really useful for getting edema down quickly. Of course, you're going to document the type of compression you used, area of the body where the compression is applied, the position that the patient was in when you did it, inflation and deflation times if you're doing pump compression, compression or inflation pressure if you're doing pump compression, treatment duration and response to intervention. So you're usually going to measure before and after. And when you're doing compression wrapping in an outpatient clinic for lymphedema, people are usually coming in 2 or 3 times a week for several weeks to get their swelling down.